Our next section is circulation. It's all about the flow, and our first speaker will be Anand Shidharani. Dr. Shidharani is a urologist who I've known for a number of years here, and he is a specialist in erectile dysfunction, and we thought we'd learn about the flow.
Good afternoon. My name is Anand Shidharani. I'm one of the urologists over here at UT Erlanger. I'm an associate professor and run the residency program there. Appreciate you guys inviting me to come talk about erectile dysfunction, which is an extremely prevalent condition affecting most men, not just in the US, but worldwide. Why I got into this was mainly due to quality of life medicine and surgery for men. I think there is a shortage of people taking care of this condition, amongst other things. Men classically haven't been a great advocate for themselves, and a lot of the conditions that men's health will entail are sometimes shameful and would prevent them from accessing good information to help them with their own quality of life and with the quality of life of their partners and relationships. So this is a very important topic, and I'm glad to talk about this today. I have one disclosure. So what is an erection and what is erectile dysfunction? Essentially, erectile dysfunction is the inability to get or maintain an erection that is satisfactory to finish, and finishing meaning climax. And the real key is satisfaction in this. So if a man is not satisfied with any part of that, he classifies as having erectile dysfunction, and usually we want to consider something that's lasting over 3 months. If it's under 3 months, it may be just a one-time occurrence. Usually those particular times are reversible. If something is really quick to occur, there's usually some inciting event that we can say, hey, that might be the reason why, and quickly make a change. If people have progressive erectile dysfunction over time, sometimes that is not reversible, and most causes of erectile dysfunction are not reversible. But the key is to acknowledge it, find out why, and risk mitigate. And these are all things done to improve their quality of life. And there could be multiple reasons for this. The big divergence is between psychogenic and organic. If a young man comes into a clinic, unfortunately, a lot of providers may say that, hey, it's all in your head. It may happen only once, and say, you know, it should get better. When in fact there is there's a high prevalence of erectile dysfunctions amongst young men as well, especially if they're type 1 diabetic, have a psychologic diagnosis or something that affects. So we should take all men coming to see us for this particular issue seriously, so we can better help them. And so what we've found over the past 10, 20 years, that there's a high prevalence of vascular disease in men with erectile dysfunction. So this can be a looking glass. Oftentimes, men will not go see a primary care doctor or any provider for their health care, and this is the first time they're actually seeing somebody to discuss a medical condition. Usually the infertility and sexual issues men suffer with will be the first time they actually see a doctor, so they'll skip a primary care evaluation, and I'll be the first doctor they'll see in years or ever, and that puts me in a specific role where I have to risk mitigate and find out, okay, what's causing this, and recommend they go see a primary care doctor to get evaluated and shuffle them around. So even as a urologist, as a specialist, I have a lot of referrals being sent out to try to improve the health issues that have caused their erectile dysfunction. And one thing which is obvious, but sometimes we'll forget, is that ED is a couple's issue. Sexual dysfunction is a couple's issue. I always like to have their partners involved in this process just so they can have some of the information. Usually there's no one to blame in this particular issue, but the men will experience some sense of shame and blame during this process. It's our job to make them feel more comfortable about it, as well as their partners, and involve them so they can both improve their quality of lives. So erectile dysfunction, like I said before, is an extremely prevalent condition. 1 in 5 men will have it. It is increased as a man will age. I like to say 40% in their 40s, 50% in their 50s, 60% in their 60s, and so on. It's not necessarily a disease of aging, though. It's most likely associated with the increase in chronic medical disease that occurs over time with these men. So the more as someone ages, they have hypertension, kidney disease, diabetes, vascular disease. All these things can increase their risk of having erectile dysfunction, as well as tobacco use, and all these things can add up and make an issue to occur where their blood flow is not that great or have a nerve issue causing their erectile dysfunction. Approximately 10 to 15 years ago, the Princeton Consensus Panel came out with some data about linking erectile dysfunction to vascular status. Now we know that erectile dysfunction in and of itself is a risk factor for an MI. So most people that I do see with erectile dysfunction, especially at a younger age, I will send them to a cardiologist or have a cardiac workup, mainly because they are more likely to have an MI. And as well, during that process as well, I do like to do a vascular evaluation, do some pedal pulses, and make sure that their vascular status is intact. When we think about an erection, how does it occur? And this is sort of a segue into how do you treat erectile dysfunction. So you have to have some stimulus, either sense of touch, smell, visual. You get excited. You send neural impulses to your penis, and the penis will have neurotransmitters that will lead to relaxation of the inner parts of your erectile tissue. You have two paired corpora, which are right here. And those relax, and they will accept blood. And as it accepts blood, it'll start to stretch, and there's a little strong outer covering of the erection right here called the tunica, and that has to trap the blood in. As the blood gets trapped, it needs to stay there, and if you have veno-occlusive dysfunction of the penis, if you have a blood flow out issue, you can even if you have good blood flow in, you can still have erectile dysfunction. Those are usually the guys who have difficulty maintaining erections more than getting them. When we talk about the main causes of erectile dysfunction, we can see here that most of it is related to a neurovascular issue, with vascular issues and diabetes being the main culprits. A lot of men will come in and say, well, I'm just started this medication, and the antihypertensive medication that I'm on is causing my erectile dysfunction, when really it's what are the risk factors for their hypertension, and that whatever that was prior was what led them to have their erectile dysfunction. Many men will come to me telling me that their primary put them on a medication. I just stopped that because that was giving me the erectile dysfunction. It's no better, but they'll stay off it. So this is a point for us to counsel them on what the real reasons why they have the erectile dysfunction. Only a small percentage of men will have erectile dysfunction related to surgeries such as prostate cancer, colorectal surgery, things like that. Most of the time it's related to vascular issues and diabetes, and unfortunately most of the time those are not reversible. What I tell men who have diabetes is that controlling your A1C and your blood sugar and your glucose control will help you not progress for erectile dysfunction, but it doesn't necessarily reverse the issue. Early on, when you just start to have erectile dysfunction, if there are significant lifestyle issues that may have led to the erectile dysfunction, mitigating those lifestyle issues could possibly work. Just weight loss, improving your diet, stopping smoking, things like that if it's early on, especially if it's a gentleman in their 30s or 40s. So when I first see a guy in my clinic, I'm going to get a good history on them about everything that they're putting in their body, how much they are exercising, what is their sexual history, do they have erectile dysfunction with one partner, with all partners, is there something that specifically happened in their life, a new stress, are they depressed? Those are all important things to assess beyond the hormonal evaluations, which sometimes will require a testosterone assessment, which I'll get to a little later, but most of the times is just seeing how they are generally living, how they view their sex life, and including their partners in that discussion. When I do a physical exam, it's a focused genital physical exam. What I'm looking for is penile length. I'm looking for scar tissue. Peyronie's disease is scar tissue that men can develop, and it has a high association with erectile dysfunction, almost 30 or 40%. So if a gentleman does say he has a new curve or a knot or penile pain, that warrants an evaluation by someone like myself to help them with their erectile dysfunction, because it adds a little bit level of higher of complexity. We do an abdominal exam and also a vascular exam. There are adjunctive assessments involved, but not for all men with erectile dysfunction. If there's a young gentleman who's in front of me, I want to figure out if they actually have a reversible vascular issue. We can perform a Doppler ultrasound. Basically, we give them an injection of vasoactive medication because we need to replicate an erection, and then we check what the blood flow in and out of the penis is. And usually young men who come in for this assessment, it's usually normal, and they may more likely have a psychogenic issue. Whenever a gentleman has an organic issue, meaning caused by a certain vascular or nerve issue, they're also going to have a psychogenic effect of that. So about half of men with an organic issue will also have some impact on the way they look at their sexual function. And even if you fix or help the organic part of it, they still may have the stigma of ED, and you also have to address that in your counseling. There has been a role for pudendal arteriography and doing vascular examinations through catheterization. There was a trial out of Mayo called the Zen trial, where actually these stenoses, if there were a 1 or 2 kind of lesion on the arteriography, were stented. Unfortunately, there was a high rate of in-stent thrombosis just due to the size of these vessels are very small. So even if it worked for about a year or 2, they found that those, on follow-up arteriography, that those stents would block. So unfortunately, we haven't had long-term success with stenting pudendal blockages. There are multiple treatment options for erectile dysfunction, which is great. There's usually first line and then second line. First line is always going to be oral medications. Oral medications have a response rate of about 70%. We're all familiar with the little blue pill Viagra, which came out in the 90s. They found this in actually the ICU population. It was actually a drug made for people who had pulmonary hypertension. They found that incidentally they were having erections in the ICU, and that's how they isolated this. Another one of those serendipitous discoveries. However, it changed the whole entire face of ED management. They do have some side effects associated with it, and they have to be taken in a very specific way to be successful. When you take Viagra or sildenafil, it has to be taken 1 hour before. You can get headache, flushing, upset stomach. There are multiple different medications to take, including Viagra, Cialis, Stendra, Avanafil. I like to use the generics just because the cost has been so prohibitive in the past, and insurance doesn't usually cover this. If you get generics, it's usually $1 per pill or less. I prefer tadalafil, which is a daily pill, which people can take, so they don't have to worry about timing, or they don't have to worry about how food intake would affect the success of that medication. And it's about $30 for a 3-month supply, so that's a very effective solution. You cannot use it if someone's on nitrates for chest pain, because it may lead to an unsafe drop in blood pressure. I always have this question: if you have a cardiac condition, can you take these medications? The answer is usually yes. It's very unlikely that one of these medications, or sex even, will lead to a heart attack. With the growing amount of men's health, I want to say the experience that men are going through has been increased. We're finding more men who have erectile dysfunction, but I think men have just become more vocal. With that, there has been a lot of direct-to-consumer marketing because it's a huge moneymaker. A couple of those things that have been grown in prevalence are these investigational therapies such as shockwave and PRP, which have other indications to use. We thought that shockwave therapy would be a great option. However, the data has been extremely poor. The data that's out there does not mimic the actual good data out of one study that shows that shockwave therapy will lead to someone who fails a pill to be a pill responder. Currently, we're using multiple different types of shocks, multiple different types of machines, and it doesn't replicate it. So if you find that someone's been recommended to do this, yes, it's not invasive, but it's probably not going to work, and it's a waste of money. It's not covered by the FDA. Platelet-rich plasma actually has worse data associated with it and involves spinning your platelets down to put growth factors back into the penis. It works better for other orthopedic issues, but the data for erectile dysfunction is extremely poor. So I would not suggest any of these options. It's just a waste of money. There are tried and true second-line therapies for erectile dysfunction. The first two are vacuum and muse, which is a pellet you place in your urethra. The vacuum is not that successful, but if you have someone with a lot of medical conditions who can't undergo a procedure or don't have the hand dexterity to give themselves a shot, which I'll get into, the vacuum can be good. It's not a erection that replicates life. It's cold. You have to use a constriction ring. If someone's like 90-95% on a pill, then they can use the vacuum and be fine. I use this more for people who have undergone radical prostatectomy and have lost significant amounts of length. This is something that can help their length grow. Mid-uterus suppositories, it sounds bad, but it's actually not too invasive. The problem with that is it's just really expensive, and it's always on back order, so we've always had an issue trying to get that. One of the more tried and true methods that's been around for decades is injection therapy. It involves an insulin syringe and injecting some vasoactive medication into the penis, into the side. Usually 15 minutes later, you can get a hard erection that's good enough for use. It's a lot stronger than the pills. About 5% risk of prolonged erection causing priapism. That's a very uncomfortable situation a man will be. They'll go to the emergency room and everybody will be like, who's the guy with a prolonged erection, or just can't have it go away. So it's an embarrassing situation. So what we do is teach people in clinic how to do it to minimize that occurrence from happening. It can also cause Peyronie's disease, which is scar tissue just from the injection going in. It's cost effective, $90 for an average of 20 shots. There's a lot of people who will charge way more, but it's really a cheap, effective option. You do have to inject yourself. You do have to have the medication with you and plan out sex, so it can get in the way of foreplay. So some people it's for, some people it's not. The other option is penile implant surgery. This tends to be the most effective and satisfactory. It's been around for 30 years and usually was rife with complications back in the 80s and 90s. We've made a lot of technological advancements to it, and it actually ends up being the cure for erectile dysfunction. And we do a lot of them, and can be done on an outpatient basis in about 30 minutes. And it's concealed, does not require refill, and usually lasts about 10 to 15 years. And very high patient satisfaction for the guys who get it and their partners, because you never have to plan out sex anymore and never have to worry about using a pill. For the people who do not respond to the pills, or they can't tolerate the injection, or they don't want to do the injection, or they're just had enough of frustration with any other ED option, that's who surgery is for. The big thing to tell men is to get from point A to point B as soon as possible. They shouldn't wait on their ED care because they can shorten up. Men will shorten 1 to 2 to 3 inches while they're if they have diabetes or vascular issues, if they're waiting on a successful ED therapy. That's why it's unfortunate if men are told there's nothing you can do, they wait and they finally find someone that will help them, and they've shortened. It's very hard to get that length back, and that seems to be a really big psychological disturbance to men seeking erectile dysfunction care. We have a couple different types of implants. The most one we use is a 3-piece. It's a silicone-based implant that we place in, and what it leads to is a, can you press play on that video, please? So it's basically concealed in the penis. If you're naked, nobody can tell. There's a little small pump the size of a gumball in your scrotum. The person pumps it up, get fully hard and erect, finish, doesn't change sensation, orgasm. You press the release valve, squeeze, and then it goes down again. And that's really the best option for men who don't get pills, just because it completely takes off the plate. Couples can be couples again, and usually the partner is way more satisfied than sometimes the guy who has it, but it's a good option for the appropriately selected individual. Why is this picture up here? Well, this is what your penis looks like after the surgery. I always say, like, it's like going through a house renovation. You get it, you look down there, and it's all bruised, and you're like, I have all guys being like, I wish I didn't go through this. They wait 2 or 3 weeks, and then finally they're real happy when they're using it. And this is actually with any sort of ED therapy. They're really happy. It changes their whole way of being. They're much more engaging. We don't really realize men with erectile dysfunction or any sexual dysfunction, they tend to withdraw from their family, friends, relationships. This is a way we can engage them and help them get back to being normal. And it's pretty easy to do. There's really easy therapies for erectile dysfunction. It's just a matter of if they want to do it and how we support them. Two special considerations. I had talked about Peyronie's disease before. If they have a knot, pain, bend in their penis, send them off to someone like me to take care of that. Some of the ED therapies like injections and the second-line therapies won't work for them. They do need either pills or surgery and other adjunctive measures. And there's specific guidelines for all these things I'm talking about, which should be followed, but not always. There's always treatments for all these things. Another thing is low T. We see low T a lot in the people we see in clinic. For me, it seems like almost every gentleman's on testosterone. You don't do it just for a low testosterone level, and if someone has erectile dysfunction, testosterone will not necessarily help alone. Men get testosterone, they get hooked on it. It's like male heroin. It causes their testicles to shrink, and then they have to do lifelong therapy to feel that way. So testosterone, even though it's easy to give, it's something we should really counsel men on, and it shouldn't be something we give men in the reproductive years because it can essentially make them sterile. So it's really important if someone has low T and erectile dysfunction, treat the erectile dysfunction first. So in summary, ED is an independent risk factor for MI, they should all have a cardiac workup and a vascular workup. Testosterone replacement therapy shouldn't be given for the management of erectile dysfunction alone. We should avoid investigational therapies. Really need to get partners involved in the care of men with erectile dysfunction if they want, and move patients along in the therapy spectrum. There are great therapies out there, and it's our job to engage them and help them with their quality of life. Thank you.
Thank you, Dr. Shrid. I think that's what everybody calls you, Shrid. And we just appreciate you, talking to us about this. It's a very common thing. A lot of our patients are diabetics, and it's a very sensitive subject when they bring it up. But it is a part of life, and we need to care for those patients. And I'm glad you're here to help us. Our next speaker is Mitch Dyson. He is the Division Director of Minimally Invasive Gynecologic Surgery at Erlanger. And we have a lot of patients that we see on the vascular side with chronic pelvic pain. And on our side, it seems to be the venous side of things. But we wanted to get the overall impression from the expert to talk about chronic pelvic pain for female.
Well, good afternoon, everyone. Thank you to the Vascular Institute for giving me this opportunity to discuss with you about the evaluation of female pelvic pain. Like you said, my name is Mitch Dyson, and I am the Director of Minimally Invasive Gynecologic Surgery at Erlanger. So why is this even important, right? Well, pelvic pain is actually a lot more prevalent than we think. Globally, about 25% of reproductive age women have some form of pelvic pain. Unfortunately, only about a third of these women actually seek care. And pelvic pain can cause a lot of distress, not just for the women themselves, but also their family. And it's a significant impact on their quality of life, their mental health, it's time away from work, it's lost income, and things like that. It also has a big societal impact. Back in the mid-90s, I think about $2.8 billion was spent treating pelvic pain. Back in 2014, it was close to $6 billion. So this is a very, very prevalent and expensive condition. Female pelvic pain, a lot of experts would say that it's just different because it's associated with a lot of the other, what you could call intimate organ systems. So a woman who has pelvic pain, there's a good chance that she might have other chronic pain conditions related to the gastrointestinal system, the urologic system, musculoskeletal system, neurologic or even psychiatric. So that's what makes female pelvic pain very, very complex. So I'm only given 10 to 12 minutes, but obviously we have a lot of conditions that can be related or causing female pelvic pain that range from gynecologic to, like I said, gastrointestinal, urologic, musculoskeletal, et cetera. So the big highlight of this is just going to be the approach to the evaluation of female pelvic pain. And this slide pretty much summarizes everything, but we'll go through it in a little bit more detail. So the biggest thing is, whenever I evaluate a patient with pelvic pain, is I want to try to gather as much information as possible before they even walk through my door. And so that is getting records from previous providers, utilizing questionnaires, and things like that. And then setting the expectation that whenever they come into my office, okay, you're here for this, just so you know, this may take more than one visit. Just because a complex pain history can be very, very extensive. So take a thorough history, do a very thorough exam if needed, and then there's also the need to complete targeted testing, lab work, or imaging studies. So like I said, it's important to gather data before they come in. Since my practice mainly focuses on surgery, if possible, I like to get previous operative reports, look at previous imaging studies, and then look at what other providers have done, because if they're still in pain, there's a good chance that something hasn't worked in the past. So again, obtaining a complete and thorough history is the most important factor in coming to a diagnosis, and that, like I said, that can take a visit or two. So when you evaluate these patients, obviously someone in pain, you want to rule out acute conditions, things that could be life-threatening, or in a gynecologic sense, a woman could possibly lose an ovary. So things that I think about initially are going to be things like ectopic pregnancies, ovarian torsions, things like that. And then during the visit, it's important to try to replicate that pain. And so one, asking a woman, what is it that you do that causes this pain? Or asking them to pinpoint the specific area where they have pain. So it starts with the history. Typically, I like to start at menarche. So menarche, when a woman has their first period, and then list the timeline of events up until the current day. So menarche followed by, well, let's see, what medicines have you tried? And it's mainly hormonal medications, so like birth control pills and things like that. Then you also want to ask about the first time that they've ever had sex, any kind of pain with sex, pregnancies, and then ask them to characterize what their pain is like currently. So pain, essentially, there are a ton of questions that you can ask, and this is where questionnaires can come in handy prior to them showing up. So I follow the mnemonic old carts, but this is just, the next few slides are just a list of a lot of questions that can be asked during these encounters. So when did the pain start? Was there an inciting event? Sexual traumas are a big thing. Even motor vehicle accidents can cause chronic pelvic pain. And then any other chronic pain conditions are really important to try to tease out. When does the pain occur? What are you doing when the pain occurs? Where is the pain in relation to periods? Or when is the pain in relation to intercourse? Is it upon initial insertion or deep penetration, or does it happen after intercourse? Just a long list of questions that can be asked to try to target whatever the next steps in management or therapy are. Always important to learn about any kind of aggravating or alleviating factors, and then what other associated symptoms there are with the pain. Do you have pain with bowel movements in addition to your pelvic pain, or do you have pain with urination in addition to your pelvic pain? So again, a lot of associated symptoms with other, with some of the other body systems. Sorry, I know that I'm just going through these a little quickly, but then we get to the examination. And the examination itself can, if you do a really, really thorough one, can take a long time. But you want to make sure that you evaluate the whole person and a lot of the other body systems that could be leading to this pelvic pain. So a bimanual exam alone is not sufficient for evaluation. You want to really evaluate every area individually. I put this slide in here because of the posture on the left. Some people would say that this kyphosis lordosis posture is like the typical pelvic pain posture. So just something to look out for in their general appearance. As far as extremities go, you want to look at muscle strength, hip flexion extension. The two main maneuvers that we will perform are the psoas maneuver, where we ask them to essentially flex their thigh, and then the obturator maneuver, where you hold their ankle still and then internally rotate their leg when it's at a 90-degree angle. These maneuvers can tease out some peritoneal signs or irritation in the pelvis or the abdomen. As far as an abdominal exam goes, we look at previous incisions, scars. Try to do like really deep palpation with a finger or two, and then Carnet sign can also be helpful. As far as in the pelvis area, this is where it can get to be pretty targeted. But I always start from the outside and then work my way in. At times, I don't even do a speculum exam though, because it may not even be warranted. But a cotton swab or a Q-tip can be really helpful if there is pelvic pain mainly on the outside with light touch. So with regards to a pelvic exam, you usually start with a single-digit exam to examine the bladder and then the pelvic floor muscles in a really clockwise or systematic fashion. So the obturator internus muscles or the levator ani muscles are usually the muscles that we try to target. A double-digit palpation or typical bimanual exam really evaluates the uterus itself, looking for any kind of masses, the mobility, and sometimes, honestly, the uterus itself is the pain generator. So this is just an illustration sort of demonstrating the clockwise fashion and how we evaluate the pelvic floor. Pelvic congestion syndrome, I am by no means an expert in this. I think a lot of providers in the Vascular Institute actually probably see this more than I do. But it is a source of pelvic pain in a lot of females. And typically the symptoms can vary in severity prior to the cycle. Usually it's worse at the end of the day or if a female has been on their feet for a long period of time, and could also be painful during or just after intercourse. You can see here a list of risk factors: multiple pregnancies, multiple birth pregnancies, so having twins or triplets, and then increasing age, maybe a family history, or even obesity. Where I come in with this, sometimes patients get referred to me because they've tried medical management. So typically medical management of this will start with some kind of high-dose progesterone therapy. Obviously there are percutaneous methods for embolization for this, but where I can come in is performing a minimally invasive hysterectomy. So the majority of hysterectomies I do are either laparoscopic or robotic, because the minimally invasive option has the best outcomes. But there has been data to suggest that doing a hysterectomy and even removing ovaries can help with pelvic pain, ranging anywhere from 60 to 80% of the time. I just put this on here too because it is just another very common pain condition in females. In fact, in a female with pelvic pain, 70% of the time, it's actually endometriosis. But this is something that can only be diagnosed by surgery. This is typically what endometriosis looks like in the pelvis. You look for these gunpowder colored lesions. They can actually also be like black or red or even white, look like scar tissue. But definitive diagnosis is by actually excising the endometriosis and having pathology look at it. I mentioned hysterectomy earlier, so hysterectomy has actually been and shown to be a treatment for some of the conditions of pelvic pain. It has a relatively high success and patient satisfaction, and specimens have shown a higher average increase in nerve fiber formation compared with uteruses from like other benign controls. So in several studies, I'm so sorry, this is really small, but essentially what this slide shows is that anywhere from, I think, 70 to 95% of the time whenever a hysterectomy was performed for pain, that was a success rate. So up to like 95% of women. So that's my talk. Thank you so much again for having me. Here's my information. Feel free to reach out if you have any questions.
That was a really good segue to what I'm going to talk about. So again, I'm Will Harrison, one of the vascular surgeons at VIC. We see pelvic congestion syndrome with some regularity, and it's probably somewhat underdiagnosed. It's very complex and has several etiologies, but we see it in upwards, we think of upwards of 15% of women between 18 and 50 suffer from pelvic pain and swelling and heaviness. Now, certainly we can see the pelvic pain, heaviness, fatigue, lower extremity pain, and cramping in people over the age of 50 as well. And some of the same pathophysiology that contributes to pelvic congestion syndrome can certainly contribute to those types of symptoms. Pelvic varicose veins are identified in the majority of those patients. I haven't done a pelvic exam since medical school and don't intend on ever doing that again. That ship sailed, thank God. And but you know, a GYN physician, as Mitch was referring to, can do an extensive physical exam and identify those, and then tell me about them later. That's some people saw ovarian. Beakley did a study in which 10% of patients, overall patients, he actually identified varicose veins with 50% of them being symptomatic on the ovaries themselves. But again, you have to work up and ensure these patients don't have other etiologies of the pelvic pain, to include endometriosis, uterine fibroma, or even a pelvic cancer. So an extensive workup, I think, is really important in these patients. Going straight to vascular treatment is not appropriate. You know, we want to work in conjunction with our colleagues in GYN to appropriately diagnose and manage these patients. Like I said, upwards of 20% of patients with superficial venous reflux that occurs, much of this is secondary to pelvic obstructive disease. And what is pelvic obstructive disease? Well, really it's blockages in the iliac vein system contributing to congestion in the pelvis, or blockages in the renal system, or insufficiency of the gonadal veins. All of these contribute to decrease emptying of the pelvic system, congestion, and then increasing pain. Again, some patients will present with gluteal, strange places to have varicose veins. Gluteal, flank, high thigh varicosities. In somebody who presents with those thigh varicosities, you should have a high index of suspicion of some sort of pelvic obstructive type pathology. And it's not limited to women. We see men with scrotal pain present with these sort of things. Varicoceles, it should always be worked up that there may be some sort of obstructing lesion that's contributing to the formation of this. These are the dilated veins on an ovary. We see it most often, again, in younger women, and we see it in patients who are multiparous. Like I said, in men, we see it. We shouldn't exclude men from this. We see it, they present with like a varicocele. Pain during intercourse is extremely common with these types of patients. Also dysmenorrhea, same sort of symptoms that you can get with other pelvic issues as well. Typically the symptoms are unilateral, but they can be bilateral in nature. And a physical exam often, like I said, can show varicosities. And so the pathophysiology of ovarian venous incompetence, a little brief anatomy lesson. This is the varicose vein, the gonadal vein here, the ovarian vein, the left ovarian vein, which drains into the left renal vein, which subsequently drains into the inferior vena cava. This is the left common iliac vein, which they probably discussed earlier today, May-Thurner syndrome, or compression of the left iliac vein by the right common iliac artery, which in cadaver studies we see in upwards of 30% of people. It's extremely common. The question is how many of those patients are actually symptomatic. But this can cause pelvic congestion syndrome as well, due to inability of emptying of the inferior or internal iliac vein into the common iliac vein. It's just plumbing. Things get congested. And also you can have compression of the left renal vein, which is much more rare, in something called nutcracker syndrome. It is where the superior mesenteric artery sits on top of the left renal vein. Classically, those are treated with a big open operation, but now they're increasing available or options for stenting these patients. Some of these patients can actually present with hematuria secondary to congestion of the kidneys. Interestingly enough, that during pregnancy, we see it in multiparous women because during pregnancy they secrete hormones that interact into the gonadal vein. Actually, if you were to sample the gonadal vein during a pregnancy, the highest concentration of hormones are in these areas, which leads to valvular incompetence and ovarian enlargement. You can actually inject dihydroergotamine into women with pelvic congestion, and in upwards of 35 to 40% of them, it'll result in a decrease in flow in the pelvis and significantly improve their pain. So how do we diagnose these patients? Our primary diagnosis is via ultrasound. History and physical, obviously, but ultrasound is incredibly important. And with a good ultrasonographer, we can interrogate the iliac venous system. We can actually visualize an ultrasound, especially in patients who are thinner, a gonadal vein and a refluxing gonadal vein, and test to see whether or not that blood flow is returning back up to the heart appropriately, or if it's getting congested and stayed in position. We can measure the diameters of the iliac vein system to see if that may be contributing, and we can also interrogate the diameter and visualize compression with ultrasound of the renal vein. CT is a good test, but it's a static test. It doesn't give us an active measurement of flow. So with ultrasound, you can actually see the flow going at one time. You can measure the speed of flow through a system and the potential for reflux, whereas with a CT scan, it's a static image, unfortunately. So you can't visualize ovarian vein reflux. Sometimes with CT scans, though, a dilated gonadal vein is indicative of gonadal reflux. Also, on a CT scan, very often you can pick up the iliac venous system and determine whether or not it is compromised and compressed. So, predictors of pelvic pain in patients with pelvic congestion syndrome, duration of reflux. If you get a report, we measure actually the length of reflux of the blood through the system, and greater than 2 seconds. We actually measure it in milliseconds. So if they report it in thousands of seconds, if it's 2 milliseconds, 2,000 milliseconds, 2 seconds, is indicative of patients that will present with pelvic pain. And then valvular incompetence of several different venous systems is indicative of patients who will have this pain. When the way we manage these patients from a surgical standpoint is almost completely endovascular. And so what we'll do is put a catheter into the gonadal vein. This is the gonadal vein coming down here. We'll actually access the renal vein from the inferior vena cava and dump a catheter into here. And the stagnant flow on angiography is indicative of pelvic congestion syndrome. And then what we will do is lay a series of coils. Coils are small metal things that almost turn into springs, and what they do is they occlude the blood flow into in the vein system. Remember Virchow's triad that we talked about earlier? Well, part of that is turbulent flow. Turbulent flow causes the platelet activation and causes those veins to close down. Now, where's that blood flow go? I mean, if you're occluding the vein system, what happens? Well, the venous drainage of the pelvic system finds collateral pathways of least resistance, and subsequently decreases the congestion in the area and relieves the pain that way. But that's not the only cause of pelvic congestion syndrome. Again, we talked about iliac venous compression. So this is something that we interrogate fairly frequently when we're looking at pelvic congestion syndrome, looking for internal iliac reflux. And several studies have shown that iliac venous obstruction should actually probably be more aggressively addressed in managing these patients. As a matter of fact, a study came out last year that said that we should treat iliac venous obstruction first prior to actually doing any sort of coil embolization of the gonadal vein, or we should treat iliac venous compression prior to any coil embolization of the gonadal vein, because in upwards of 75% of these patients, they will get complete resolution of symptoms. So that's become, since these papers have come out, that's become our algorithm, is to attack the iliac venous compression first, and then if that doesn't completely resolve the symptoms, then we'll often go to coil embolization. I get a lot of patients who come in with this type of pathology who potentially want to become pregnant again, and this treatment does not preclude them from that. As a matter of fact, if we do go in and stent the patients, the incidence of thrombosis of the stents while they are pregnant is extremely low. The stents have a tremendous amount of radial force and do very well in that system. One reason that we do see it in patients who are multiparous is that the gravid uterus sits on top of the iliac artery, which subsequently sits on top of the vein, which is very pliable, causing the compression and causing the chronic issues. So this is the final video that I think is really important. This is a patient we treated, and hopefully you can see it, but this is a CT scan afterwards, and you can see the iliac venous stent coming up right here, and let me play it again, and the coils running down right here. So she had multiple GYN operations prior to presenting with this persistent issue, including a hysterectomy, and patients can still have these issues and pelvic pain and everything else, even despite hysterectomy. So very interesting pathology that we're still exploring and learning. And we do these procedures mostly in our office. Iliac venous stenting is very, very safe. It's an outpatient procedure. They come in and go home the same day. Sometimes we'll prescribe them medications, but the incidence of major complications is exceedingly low. I would say it's probably even less than that now as we gain more experience with it. Thanks, appreciate it.
Thanks again for allowing me to present. I'm Frank Quazzo from Portsmouth Naval Hospital. We're going to talk about DVT management. DVT management, I would say that I have no disclosures. Every good talk with DVT management starts out with Virchow's triad. Stasis, hypercoagulability, and vessel wall injury are the key components of vessel thrombosis, and you'll see that many of our hospitalized patients have at least one of these risk factors, and even our outpatients have these risk factors as well. Raoul, the first recorded case of a DVT was actually in 1271. It's written in this French manuscript, and this guy Raoul, a cobbler, developed pain and swelling in his leg, and he went to go see a surgeon, and the surgeon really said, oh, let's just wait and see what happens. And he eventually developed a wound, and then he went to this shrine, which I guess the local hospital, and they couldn't help him. So he went to the tomb of St. Louis and prayed and rubbed some dust on it from the tomb, and magically it got better. So what if you don't have this magic dust? We have VT is a major source of mortality and morbidity. There's over essentially 2,000 deaths per year to DVT and PE. There's an incidence of over nearly a million incidences of it. 33% of the patients have a long-term complication, post-thrombotic syndrome, or recurrence of DVT. And if you look at our kind of ranking causes of death in the U.S., it ranks very high. Now, we've seen post-COVID-19 an increased uptick in the cases of DVT and PE, and this is a study out of Sweden that looked at over a million patients. It showed that after COVID-19 infection, they had an increased risk of DVT, PE, and bleeding as well. And the more severe case of COVID-19, the higher the risk. It extended out for 3 months for DVT, 6 months for PE, and bleeding for just a couple of months. So the diagnosis of DVT, you start actually with a good physical exam and history. You can use clinical decision aids like the Wells criteria, which we'll go over in a minute. D-dimer is a blood test that you can get. It's very good for ruling out a patient if it's negative in a patient that has low risk. Of course, duplex ultrasound with compression is if a patient has high risk, positive D-dimer, then you want to proceed with a duplex ultrasound. Here's our Wells criteria. It's a list of symptoms that you can add up. And if you have 3 or more, your DVT is highly likely. There's a modified criteria that says if you've had a history of a DVT in the past, you automatically get 1 point. And then any of these symptoms give you 2, and your DVT is likely. So here's your initial algorithm for treating DVT. If it's likely, then your D-dimer, if your D-dimer is positive, your Wells criteria is positive, then you go with an ultrasound. Diagnose either no DVT or proximal or distal, and then you treat as appropriate. The treatment goals are basically you want to prevent clot extension, you want to prevent the risk of PE, you want to reduce the risk of current or recurrent thrombosis, and you want to try to avoid the dreaded post-thrombotic syndrome, which is essentially you feel like you have a DVT chronically and you don't have one. Obviously, you want to treat massive iliofemoral thrombus if a patient presents with venous gangrene or ciliary phlegmasia. That is an acute surgical emergency. So anticoagulation is the mainstay of treatment, and this is a series of studies done in the 1940s, 1950s, and 1960s, and that's when we really saw that it was important to treat these patients with anticoagulation, and if you didn't, they would die. There was a study, the Barrett study up here in the UK. They didn't treat 19 of their patients, and their patients actually started to die, and they stopped the testing, and they treated them all with a coumarin derivative. So this is where we kind of get the idea that anticoagulation helps. We have multiple different drugs now for anticoagulation. That we have the conventional pathway with heparins, and extending to a vitamin K antagonist like warfarin. And we saw a very good review this morning by Dr. Harris of when all these medicines came about and how. We also have the novel agents, the direct oral antagonists or anticoagulants, and these are the factor Xa inhibitors or the direct thrombin inhibitors. The DOACs really are have been shown to be very easy to use for patients. They have high efficacy and low risks. They offer greater convenience for patients. However, it's very important to know the patient's history to know if these are not indicated or contraindicated for the patients. Also interesting to know is that the two that we use most is Xarelto and Eliquis. You can use them for all phases of a DVT, which makes them extremely convenient. There are other two, the dabigatran and doxaban. You actually have to use a heparin lead-up for that. So the chest guidelines have been really very helpful in terms of treatment for DVT and their recommendations. They've been publishing guidelines, I think, for the last 40 years. They came out with a recent updated guideline at the end of 2021 They hadn't really put out a guideline since 2012, and they have a lot of different and newer. So we're going to go over some of the newer ones and some of the more controversial. They're arranged according to phase. So there's an intro phase, and then a treatment phase and an extended phase. And then they talk about precipitating factors, minor or major. A minor factor is present 2 months before the event. A major factor is 3 months, or if there is a persistent factor involved. So this is their newest statement about the DOACs. They do recommend the DOACs right now as first line of treatment if there is no contraindication for the patient. Extended phase therapy is essentially not recommended for anyone that has a transient risk factor, major or minor. They recommend just 3 months of therapy. Extended phase therapy is recommended for an unprovoked venous thrombotic event or provoked by a persistent factor that does not go away. And again, they do suggest that the DOAC should be first line. Now, the treatment of a distal DVT, this is interesting because this is a consult that we get from the ER and different doctors at various times to us. What to do about a distal DVT? A distal DVT is a DVT that's essentially below the knee. It's either tibial or muscular in nature. And the answer, the recommendation is that serial imaging over 2 weeks is actually fine if the patient does not have severe symptoms. If there is, especially if there's a high risk of bleeding, it's a fine way to treat this. And if there's no propagation of the clot after 2 weeks, you don't have to treat. Oral anticoagulation is recommended for patients who do have a high risk or they do have propagation of the clot after 2 weeks. Compression stockings and early ambulation, I actually comment on this. For years and years we've been saying you got to put your compression stockings on, you got to walk early. And I would still recommend that for your patients. I think it helps to reduce acute symptoms of DVT, but when they look at the data, they did not see any demonstration that it actually reduced the risk of developing post-thrombotic syndrome. Again, this is a question that we get all the time. Well, what about an IVC filter? An IVC filter is not recommended in anyone that doesn't have any or contraindications to anticoagulation. So if you have an acute DVT and the patient can be anticoagulated safely, IVC filter is not recommended. When it is recommended is essentially if you have an acute proximal DVT of the leg that is above the knee and there is a contraindication to anticoagulation. What about a distal DVT and a contraindication to anticoagulation? I got this consult literally 2 weeks ago. An 80-year-old guy in the hospital admitted for a GI bleed, complained of some leg pain. They scanned him and they saw that he had a gastroc DVT and a soleal DVT. So they consulted me and said, hey, do we need to put a filter in this guy? And so the recommendation is you don't have to. You can do serial duplex. And if it propagates, then yes. However, you have to also look at his history. If he is a high risk factor for venous thrombotic events, then you probably want to go ahead and do it. This guy had a GI bleed from a totally unknown cause. He'd never been scoped before in his life, so we actually made the recommendation of putting a filter in him because we couldn't rule out an underlying cancer. So cancer-associated thrombosis, what is the recommendation? The recommendation is actually for DOACs, to start a DOAC. However, the one exception is if there is a luminal gastrointestinal malignancy, you probably don't want to use Xarelto. There's a higher bleeding risk with that, and Eliquis or Lovenox would be what you wanted to choose here. Anticoagulation in pregnancy is safe. We know that pregnancy is a risk factor for venous thrombotic events. The agent of choice is low molecular weight heparin. It's very safe throughout the course of pregnancy. Of course, you want to stop 24 hours prior to delivery. Postpartum, though, you can actually convert to warfarin, and it is safe even if mom is breastfeeding. What about a superficial venous thrombosis? So again, this is kind of like the distal thrombosis. The chest guidelines recommend anticoagulation for 45 days only if there is a high-risk patient, or you have an extensive clot, it's near the saphenofemoral junction, they've had a DVT in the past, or they have active cancer. And again, the treatment is 45 days, recommended fondoparinux, or you also can use a 10 milligram daily dose of Xarelto. So again, here's the crux of the issue here. Now the chest guidelines, we've talked yesterday a lot about the means of endovascular intervention for venous, for DVTs, especially iliofemoral DVTs, and why now the vascular surgeons are really in the game for this. They actually recommend anticoagulation only for acute DVT. And if there is a limb-threatening DVT, like major pseudodolens or venous gangrene, then to intervene. All this to say, I think that if you have a patient that does have an iliofemoral disease or iliofemoral DVT, to me, that is a lifestyle-limiting condition for your patient. We treat it for arterial disease, and I would highly encourage you to get your vascular surgeon involved in that patient, despite right now what the chest guidelines are saying, because I think this needs to be individualized per the patient. We go through the data a little bit of why they're recommending this. These are some retrospective reviews. They had a Cochrane database review that said they really didn't see a difference in post-traumatic syndrome in patients treated with thrombolysis versus anticoagulation alone. There is several randomized clinical trials. This is the Torpedo trial. The Torpedo trial actually did show a difference in lowering recurrent DVT and decreasing symptoms of post-thrombotic syndrome. This is the Cavent trial. This is a little bit of a larger study. And this also showed a difference in post-thrombotic syndrome in patients that were treated with thrombolysis. It was demonstrated by patients with a LALTA score, which is a venous DVT, basically specific score based on clinical symptoms. So this also showed somewhat of a difference. This very large ATTRACT trial was almost 800 patients in 56 U.S. centers, treated by pharmacomechanical catheter-directed thrombolysis. This study did not show a significant difference in post-thrombotic syndrome and had a little bit higher, had significantly higher bleeding events in the treatment. But this study was plagued by incomplete follow-up, and most of the people that didn't follow up were in the control group, so that underestimated the treatment effect, I believe. This is a subset that came out in circulation looking at basically the people in the ATTRACT trial that had iliofemoral disease, specifically to see if the iliac component made any difference. And the results basically said that there was not a significant difference. I do want to talk a little bit about management of post-thrombotic syndrome. I think when there's a lot of patients out there with this, I think maybe partially because their iliofemoral DVTs potentially weren't treated. The biggest thing with these patients is you have to rule out a central venous obstruction. You have a central venous obstruction, that is a referral to a vascular surgeon. That's something that we can help with, and that can be ruled out by an ultrasound duplex exam. It doesn't have to be a fancy MRI or CT. We can get an ultrasound duplex and have a pretty good idea a central venous occlusion. The other thing about these patients is a lot of them are overweight. If they just would lose, 20 to 30 pounds, their symptoms would significantly decrease. We heard about exercise this morning with increasing muscle strength, and that's very, very true in patients with post-thrombotic syndrome. Your muscles are a secondary pump and can improve your symptoms greatly. Again, compression hose is a key component of this therapy, as well as compression pumps. And we have a vendor, BioTab, outside that has some good compression pumps. I like Normatec as well. I have patients that basically start their day with a compression pump, put their compression socks on, and then end their day with a compression pump, and they're actually able to maintain their symptoms fairly well. And then finally, kind of on the horizon for venous insufficiency is this surgical venous valve replacement or creation. There is a new device in trial, in a clinical trial right now. It's called Blue Leaf, and it's in trial at EVMS, which is next door to us. It actually can create these venous valves, and I'll show you the picture. It actually endovascularly enters the vessel and sends a little sharp device into the layer of the vessel here, and actually creates an intimal flap. And then it sprays this saline, increasing the size of the flap, and then puts a tool in and creates this cusp. And it's done under IVUS. There's an IVUS component of this as well, and it's done under IVUS guidance, and you actually can see the cusp form. You can form a monocusp on one side. You actually can form a bicusp on each side. So this is kind of very interesting. It's not surgical, not open surgical, it's endovascular. It's done as an outpatient. So far, the early studies on this, there hasn't been, are very good in terms of the safety and efficacy. They have a very low risk of DVT, almost no DVTs so far in this study. So I'm looking forward to seeing the results of the trial. So in conclusion, for DVTs, again, I can't recommend enough, it is a lifestyle limiting disease. I think we have to have a high degree of suspicion for our patients that have it. We have to treat with anticoagulation early, with the recommendation of DOACs being the first line of treatment. I think when you have extensive iliofemoral disease that's severely limiting a patient's lifestyle, you definitely ask your vascular surgeon to evaluate them and come up with the best plan, definitely in the acute setting. Much easier to treat these patients in the acute setting than down the road when they have chronic disease and post-thrombotic syndrome. Thank you. This is our Naval Medical Center, Portsmouth. We are the first naval hospital in the United States. We've been treating patients since 1830. Thank you.
Thank you. We are doing very well with time, but I think we are going to take a 15-minute break and restart at 3 o'clock. It's going to be the medical management of vascular risk factors. I think it will be great to hear a little bit more about that, and then finishing up with some of the mission work in the region. And Frank, I do agree with you. I think it was a great topic. Some of these complex DVT patients, patients with iliofemoral or patients with pain or severe swelling, it might be worth a consultation, because some of those patients we can actually go after and fix versus just leaving them on anticoagulation and hoping they get better. So I think it was a great talk. We'll see everybody back around 3 o'clock. Thank you.